So Dr. Yoldas, the patient comes in, he's, I don't know, 22 years old, 23 years old, and he's got a meniscus tear. Kind of walk us through your thought process in terms of repair, meniscectomy, how you make the decision, and maybe different repair techniques that you thought worked and repair techniques that maybe didn't work.
Sure. I think obviously you look at, it's a cliche term, joint preservation. You know, we're trying to not cause any injury. What the term is iatrogenic. So my job is to get what can heal to heal without causing any further harm, right? Prima non nocere, first do no harm, what we all say in med school. So you look once again at location. I can be the most amazing person at stitching meniscus tissue, but if I'm stitching it in an avascular zone, it will not heal unless we have some new technology that develops over the next 10 or 20 years. So location is important. What I tell the patient also is that each tear has its own personality. I may have an intent and a will to do something, but until I see it in the joint and its location and tissue quality, I might have to move right or left, so to speak. But you always look for that role. So with the intent of trying to repair it, let's see, I find a longitudinal tear in the vascular zone, what they'll say red or red-white zone. You have a couple different techniques. Historically, and even maybe currently, one of the more satisfying or successful techniques is called inside out, where we bring some suture material from inside the knee out. That can be done arthroscopically, but requires an accessory incision to the back corners of the knee, medial or lateral, and it takes an experienced surgeon to be back there, to feel confident back there, to receive needles being passed through the knee so it's not causing any other injury in those areas. And there's some big, nasty stuff there. So that historically has been done a long time. Over the past 15 to 20 years, we've gotten better with what we call all inside technique. And yes, over the past 15 years or so, I have migrated to an all inside technique where arthroscopically we pass the suture material through, it fixes on the backside of the meniscus and you cinch it down, literally sort of crimping it. There's always a new widget, a new way of doing it. There is a little bit more technical fuss factor sometimes with some of the designs, but it seems to be more appealing because it's less invasive. There's less incisions being made, but you have to look at outcome. And as far as I'm aware of, the outcome comparing inside out versus all inside is a push. One isn't necessarily that dramatically better than the other at the moment.
So if you're going to do an inside out technique, you make your incision in the posterior medial, posterior lateral corner, then you retrieve these long skinny needles. Then what do you do? I mean, now you got these two needles sticking out of the incision. How do you secure the meniscus? Yeah,
so in these techniques, and for the casual person observing, these needles are long. They're, I'm not sure, 5 or 6 inches long. First thing you do, you tag them, you cut the sutures and you tag each one to make sure you're tying the right ones to the right ones, because you could have several being passed through there. So you might have 4 or 5 different pairs of these sutures coming through the back. And then what you do is you try not to over capture the knee. So you put the knee in a little bit more natural position, if you will, not overly extended, not overly flexed, such that when you tie it down, you're not tightening other concomitant structures, which would then make the job for somebody like Joe a lot more difficult and more painful for the patient. So a little bit of artistry of not just putting the suture in, but how you tie it and how you secure it.
That's excellent. So it sounds to me like the all inside technique would be a little easier. You got a widget, you place your anchors, you tension the anchors, and a little bit safer, maybe a little bit quicker.
Yes, a lot quicker, and less need for an assistant per se. Before, you would need definitely 2 sets of good hands to be in arthroscopically and to catch those long needles, where an all inside technique, theoretically, you could do it a little bit more fastly by yourself. It's always nice to have an assistant, but it's possible to do it with less manpower, so to speak.
And tell us what happens between taking the meniscus out. So you have a white tear or a red-white tear. Your assessment is, well, this meniscus is not going to heal, so I'm going to do a partial meniscectomy versus I'm going to do a meniscus repair, number one, and then maybe secondarily, patient comes back 2-3 years later, did pretty well, re-tears her meniscus, after a meniscus repair, which we've all seen. Tell us how those 3 sets of patients are going to do. Number one, the guy who has a meniscectomy, 23, 24 years old. The person has a repair that's successful, and the person has a re-tear.
Taking the easiest first, the young person would say a small radial tear that you cleaned up. You know, it's a 20-minute procedure at most. You know, they're on crutches for a handful of days, and as Joe was alluding to, they can get back to more impact activity pretty quickly. Let's just call it 6 weeks, plus or minus, thereabouts. It's a different animal with a repair. When you repair that tissue, despite our technology and despite our sutures, repairing a meniscus, I tell people, is like sewing tissue paper to each other. It's delicate. So there are different ways to go about it. Some of the literature says a little bit more aggressive, a little bit more conservative. I still tend to put them in a brace just as a mental reminder to sort of slow down in case they have a slip and fall. I do initiate partial weight bearing right away. I want them to put some pressure on it. I think that's good for the muscles and the bones and actually some of the synovial factors within the joint. And ideally by 3 or 4 weeks after the procedure to get rid of the brace and crutches. However, I really don't want them doing impact, run or jump for 3 to 4 months per se, depending on how they're doing. So one's a very quick recovery. One is a several month recovery. And the intent is that by repairing the meniscus, if you have done that, by taking that part of that tissue out, you would have put them on a road for quicker degenerative changes because you took out too much. So you're preserving more of a years and decades type of knee for them. So you're paying it forward. The last person is a very difficult situation, and I think it happens more than we care to admit, and I think the literature is a little bit biased in missing these. I think many meniscus tissue are repaired surgically, but I don't think that they often heal biologically. I think they create sort of a fibrous, stable pattern. So people do well, as you alluded to, 2-3 years, something happens and it re-tears. It may never have been fully healed to begin with. So now you're fraught with a difficult decision. Depending on age, are we dealing with a 25-year-old that this happened to, or are we dealing with a 45, 50-year-old? That may tip the discussion one way or another and saying, hey, let's just clean up this torn meniscus, modify our activities, you know, no impact, biking, swimming, your days of playing hoops 3 nights a week should be eliminated. Or while you're a 25-year-old NFL player, that this is your livelihood, we got to re-repair it, throw some biologics in there, maybe even old fibrin clot, all this stuff to try to get it to mend. So it's not an easy situation. It sounds simple for such a small structure, but it can impact a lot.
So a re-repair, tell us about your biologics. Do you PRP them at 6 weeks? Do you do some type of amniotic combination? Do you think it really helps? And what is your time frame in terms of biologics, let's say for an index repair or a re-repair of the meniscus?
I will say I'm a believer in the biologics, but I think I have some good common sense. I was an engineer undergrad, so I tend to look at things a little bit with a critical eye. To me, when we repair a meniscus with an ACL, as we all know, you're releasing all these bone marrow factors, stem cell factors into the joint. Nothing to me needs to be added additionally. However, if you have a meniscus repair isolated and without stimulating the bone marrow, you could make an argument to do that. I'm going to take a pause that I believe there was a recent paper in AJSM looking at the genetic origin of the cells at the repair site, and they are synovial cells. Now, historically, and I'm sure in your training too, whenever you repaired the meniscus, you took a little mini rasp and you would scuff up the synovium right at the border of the meniscus to induce healing, bleeding, reaction. And it seems to be those cells that migrate to the repair site. With that being said, could I be okay with, and am I okay with somebody asking, hey, at that 6-week mark, I think some PRP or stem cells, I'd like to do that. I believe there's no harm in that. I think the literature is still lacking in terms of efficacy on that. However, as we both know, there are some people who will throw the kitchen sink and their bank account at certain things. As long as they're not harming themselves, if I can look at them and say, I don't think you're harming yourself, I'm not sure if it's efficacy, they wish to move forward, sure. So long-winded answer, I'm okay, but typically 6 weeks, but I'm not a proponent of it just right off the bat.
Excellent. So Joe, Dr. Yoldas just finished repairing a meniscus. And in his second case, he took out, like you said, a small radial tear. Both these patients come into your clinic. They're young, they're fairly healthy. Walk us through the rehab of the repair versus a partial meniscectomy. And Dr. Yoldas made some very, very good points. And, you know, I think we've all had athletes. I had a guy the other day, as a D1 wrestler came in, he said, would someone else repaired his meniscus? He said, don't re-repair my meniscus. You know, I got wrestling practice in 2 weeks, and whatever you do, don't make me non-weight bearing and don't limit me. So everyone's going to get that comment sooner or later. So walk us through the rehab for those two different patients, please.
Little kind of premise first. I can say, so I've been PT for 10 years now. And when I first started, there was definitely kind of just a standard that we were going non-weight bearing with a repaired meniscus, right? And as Dr. Yoldas alluded to already, we get that repair in, we're definitely going to have some type of weight bearing restriction there for some amount of time. But we do want to get them weight bearing as soon as they can. So that's something that I've definitely seen change over the course of my time as a PT. Now, the first week, 2 week goals, for the most part, are almost the same. That person's coming in, whether it's a repair or a meniscectomy, we want to get the post-operative edema down so that they can function a little bit better. Because our first goals of regaining extension and regaining that good voluntary quad contraction are not going to be achieved without the reduction of edema. As we know, it's going to really slow down the signals to the muscles if there's a lot of swelling in there, and they're just not going to be able to contract enough. So those will always remain first and foremost. We want to get that leg straight, and we want to get that quad functioning really well. After that, it's always going to start off with a lot of open chain exercise with our straight leg raises, whether it's repair or meniscectomy. If it comes to a repair, there's going to be some communication there that if Dr. Yoldas does need me to back off of how far I'm flexing that knee, especially once we do start weight bearing, that may be more patient to patient depending on the type of tear that he repaired and how serious it was, how involved it was. So that may vary a little bit case to case, but in terms of the meniscectomy, we want full range of motion as fast as we can get it. From there, as we get into more of the weight bearing considerations, if it's a meniscectomy and after that first, couple days, that patient can really start to do a lot more, especially as we get into that second week. We want them off of their crutches as fast as we can because there's just so much muscle activation that they're going to benefit from. The longer they kind of stay afraid of it or walking with too much of a gait impairment, really trying to unload it, it's only going to get in our way for the long term. So as long as it's not creating a lot of edema on the knee to weight bear, then we want to try to progress that as fast as we can and even build into the leg press and squatting patterns as fast as we can. For the repair, it's obviously going to happen a little bit slower, but we want to keep in mind that when Dr. Yoldas tells me 50% weight bearing, I can get that person on a leg press. I can get that person in a pool if the wounds are healed enough, right? 50% weight bearing we can work with. So once we get to those points, I may not be as aggressive, but I'm certainly working the same patterns. Now, as long as, we're talking mainly about getting the quads, hamstrings, and calves going when we talk in regards to that. Now, I'm also going to do as much as I can to work their hips and ankles in a closed chain pattern when they're ready. But if it needs to be open chain, I have a lot of leeway I can take there. And that's where, your classic first week stuff with the straight leg raises comes. And then I can build that into banded lateral walks once they're weight bearing more. And then now we get more into our late stage rehab. That's when we'll really start to focus on a lot of unilateral closed chain tests. So being able to do step ups, lunges, any type of single leg squat patterns will be really important for getting the hip, knee, and ankle to all function appropriately to get them back to their prior level of function, back to sport, back to a physical job. So very similar. There's just a little more caution that we're going to take with that meniscus repair, depending on how involved the repair was. But most literature that we've seen, and like I said, as long as Dr. Yoldas gives the okay, The earlier we can weight bear somebody, the better their results are going to be and the faster they're going to get out of physical therapy and be able to return to their activity.
Joe, when do you expect that meniscal repair patient to go back to playing high school basketball or pro baseball?
High school, they also little, again, premise there too. We got to consider who we're talking about. When I have my professional athlete, my high level college athlete, maybe some of my high school athletes, there's, besides for just the healing process, there's a little bit of just what the capacity of their body is and what they can take and their knowledge of how much they've worked out on their own in their life. So a professional athlete, I may be able to get back a little bit faster because maybe they've been through a lot of high level training. But in general, we're still going to say that it's going to be a minimum of 3 to 4 months, because if we have a little bit of non-weight bearing time there or really partial weight bearing, it's just going to take a certain amount of time to get the muscle mass back and the strength back. It's unrealistic to think, we'll even take it a step further with a microfracture procedure. If you're non-weight bearing for almost 4 weeks, your strength isn't going to come back for quite some time. With the meniscus repairs, it's a little bit of a faster timeline, but it's that initial phase of not really being able to start working on building closed chain strength that's going to delay it and push us back to that 3-4 month period that we usually start with. And then from there, things may get adjusted a little faster, a little slower.
Excellent. That was excellent. So Dr. Yoldas, just to kind of close, I want to hear your thoughts on meniscal transplants, lateral meniscus, medial meniscus transplants. What are the indications? Are there any indications? And generally what your thoughts are.
Yeah, interestingly enough, I had done some research on this, or a few research papers in my residency with Dr. Chris Harner and a few others at the University of Pittsburgh on this subject. And basically, you're putting a piece of tissue in when you have lost all the native cushion or all the native meniscus. And hopefully, and fortunately, we have a lot less of this. However, 30, 40 years ago, a near total meniscectomy sometimes was standard of care in certain parts of the country or certain parts of the world. So you see this patient population more often. We're seeing it less and less. When we look at the data more currently, you have to first off make sure that there's no mechanical misalignment, that they're aligned neutrally, as they would say. You can get them to function well. However, it is never made for them to be, I'll use this word a little heavy-handed, an athlete. It is more for activities of daily living, enjoy some good casual things, doubles tennis, etc., pickleball, whatever it might be, and play some golf. But it's not intended for you to do a meniscus transplant with the intent that they're going to play minor league baseball or something like that. But I think the population where meniscus transplant is indicated for is shrinking twofold. One, we're seeing less of these type of patients, and then B, in the future, we are going to have different forms of scaffolds or tissue that we can augment. People have been trying for decades. None of them have worked great, but that is going to be sort of a substitution or a change in our approach to it.
Thank you. So in closing, Joe, additional thoughts. What did we miss? What should we add? And I'm going to ask Dr. Yoldas the same question. What are some additional pearls that we can add for the therapists out there who are treating these patients?
I think, the most important thing, Dr. Yoldas really alluded to it at the beginning, is tempering expectations dependent on the case. We touched a lot on BMI earlier. We've touched a lot on age and degenerative changes. So really educating the patient on first the status of, I guess we'll say, their structural state, right? What type of injury they had, how bad was it? And then from there, talking to them about how their life contributes to it. I think that a lot of therapists struggle with this, maybe for different reasons. Maybe they're just not comfortable talking with somebody about their body weight. But I do think it's something that, in my personal opinion, always needs to be brought up and addressed. I think a lot of therapists are really good at taking their education further, learning how to do this new exercise, learning how to teach these body mechanics, but really relating to the person on their level and speaking in terms of what their lifestyle is here to include and how to get them to have the quality of life within their capability and their capacity according to their injury is by far the most important part. And I think sometimes it gets a little too much to be, the patient comes in and they're like Dr. Yoldas said, he tried to tell them that they can't make it perfect, but they're expecting their knee to just be perfect as fast as possible. Sometimes those things are just going to take time. And that's a hard conversation to have with some people. And especially when concerns come up with insurance limitations and stuff like that. And, honesty is the best policy, is I guess the best way to say it. And I truly think that that's the most important thing, to really get on a level playing field with a patient right off the bat, and then continually talk about those things as we go. From more of a treatment standpoint, more of an objective standpoint, I think it's more so giving the patient the tools that they need in order to achieve their goals. So, if you got a patient that does not have a gym membership, gotta tell them, you gotta get a gym membership. This isn't a choice. If you don't have equipment at home, I'm gonna need you to do these things. If I need a patient, the pool program is really fitting on them, I gotta tell them, look, if you don't have a pool, you need to go somewhere you can get in a pool. So, providing the patient the education, make sure they understand how important it is that they follow through with these things, that's what's going to give them those lasting things. So I think it's much more of a communication thing that becomes the important factor in a successful rehab, rather than my one special technique or my one special exercise. That makes so much of a difference, because there's such a plethora of things out there. And I've used so many different things over the course of my career. And sometimes I go back to things that I haven't used for years. I'm like, yeah, I'm back on that exercise, using that with a lot of patients. Maybe it fits that person, or maybe I've just gotten away from it, in lieu of something that seemed a little fancier and more exciting for some patients. But sometimes the basics are the best. So I think the communication, both lifestyle wise and educating them about their status, is still the most important.
Excellent. So it sounds like you really have to manage expectations. And I think that seems to be a recurrent theme in the orthopedic literature as well. Like you said, if somebody expects that they're going to run the Boston Marathon 3 days after their knee arthroscopy, that's just unrealistic. And I think that's really a good point for all of us. Dr. Yoldas, closing comments. Give me what we missed, or what we should add, and anything specific that you think is important.
I think, to echo a little bit of what Joe said, I'll mention two things. One is, to paraphrase what I said before, everything is individualized. I think when I was a younger physician, you have this timetable. They have to be ready at 4 weeks. They have to be ready at 8 weeks. And you realize as you go through, people are different. People have different reactions to injury. They have different mental makeup. They have different motivations. So allowing a little bit of latitude along with that communication, you'll be happier and the patient will be happier, as opposed to getting them some goals that they cannot reach based on their own physiology, anxiety, confidence, all these things. So being attentive to that from the therapy perspective and also the physician perspective works. Secondly, I think we also have to remember there's a difference between, let's say, running and playing football. And these expectations are, hey, you can run at 8 weeks, but you know what? If you get on that field and expose yourself with just a half second of slowness, you could cause more injury. And I think with most people, it's saying it's one thing to sort of practice, it's another thing to perform. And I think you have to build that into certain people's discussions. Obviously, not everybody's a professional athlete. The vast majority of us are just Joe Weekend warrior. But even so, there's a difference in functional strength, functional ability, without getting pride in the way for a lot of patients' recovery.
You guys, as always, you were both great, and I really, really appreciate it.